Welcome, everyone. Thank you so much for joining us this evening, for taking the time out of your day to join us for this webinar. I would like to start by welcoming all of you to this webinar on behalf of the Utiva team. We're very excited about today's live session as we have a very knowledgeable and passionate urologist with us today who will be discussing some very practical approaches in handling common UTI cases. So Utiva is a company focused on natural UTI prevention. My name is Jyoti Nanda, and my role at Utiva is working in sales and marketing for the professional side of the business. With me here is Derek O, who is one of the two co-founders of Utiva. Give a little wave.
Hey everyone, thanks for joining.
So today, just a little bit of housekeeping. Today's talk is going to be approximately 20 minutes. It'll be followed by a live Q&A, and then we'll end it with a live raffle for anyone that's currently in attendance. So be sure to stay on till the end. In the case that your name is chosen from the raffle, you'll need to stay on and let us know that you need to stay on to claim it. And if you have any questions for the speakers, just be sure to, for Dr. Shah, be sure to enter it into the Q&A, and you don't need to wait all the way until the end of the presentation. As your questions come, just enter them into the Q&A, and we'll be keeping track and have them ready to go when the Q&A portion begins. And with that, I will like to introduce Dr. Milan Shah. So Dr. Shah is a board certified urologist who's currently practicing in Los Angeles, California. He completed his undergraduate training at the University of Pennsylvania. Prior to entering medical school in New York, he actually worked in people operations at Google. He completed his urology residency at the Icahn School of Medicine at Mount Sinai, followed by an endourology fellowship at Loma Linda. His clinical interests include kidney stones and non-pharmacological urinary tract health. And without any further delay, please welcome Dr. Shah.
First and foremost, I just wanted to thank all of you for taking time out of your schedule to join us. And so today I'll be talking about recurrent urinary tract infections, best practices, and non-antibiotic prevention options. If you can all see my screen. So a quick look at the numbers. It's estimated that approximately 150 million people are afflicted with urinary tract infections each year worldwide. And of that, approximately 8 million people get a UTI each year in the United States, accounting for an estimated 10.5 million office visits for UTI symptoms in the US alone, and with an estimated annual cost of $3.5 billion. And these costs include not just visits in the hospital, but also the diagnosis, the evaluation, the management, and the time missed from work. We often clump urinary tract infections into just urinary tract infections. When patients go to an urgent care center or a hospital, they'll often see a patient with different types of symptoms, and they'll say, "You have a urinary tract infection, go see a physician or a healthcare provider." But these definitions are really important in classification because they do affect our evaluation, our management of these patients. So we define ABC, or acute bacterial cystitis, as a culture-proven infection with a bacterial pathogen that's associated with acute onset symptoms, such as dysuria. In uncomplicated urinary tract infections, these usually occur in patients that have no known factors that would predispose her to more susceptible to develop a UTI. And with complicated infections, there are other complicating factors that may place one at higher risk for an infection and or decreased treatment efficacy. For example, if someone has an anatomic or a functional abnormality of the urinary tract, if they're immunocompromised in any way, or if they're prone to being infected with multi-drug resistant bacteria. When we discuss recurrent urinary tract infections, the AUA guidelines discuss this as two separate culture-proven episodes of acute bacterial cystitis and associated symptoms within 6 months, or 3 episodes within 1 year. There's also something called ASB, or asymptomatic bacteriuria, which is the presence of bacteria in the urine that causes no illness or symptoms. The symptoms that women often experience with infections include dysuria or burning, which is one of the predominant symptoms that are present. And it may be associated in conjunction with variable degrees of urinary urgency, frequency, hematuria, which is blood in the urine, and new or worsening incontinence. Central to this diagnosis is dysuria or burning. These other symptoms, again, are variable in nature. These recurrent infections, as I mentioned before, 2 within 6 months or 3 within 1 year, they're typically considered to be separate infections with the resolution of symptoms between episodes, and do not include those who require more than 1 treatment or multiple antibiotic courses for symptomatic resolution. It's important not only because patients are symptomatic from their acute onset symptoms, but if left untreated, this can progress to pyelonephritis. And there is no specific threshold for urinary colony count that has been demonstrated for patients who can progress from a urinary tract infection to full-blown pyelonephritis, or those who would benefit from more aggressive antimicrobial management. Though we typically have learned that greater than 10 to the 5th colony-forming units is sufficient in the properly selected patient when there's a strong suspicion of infection, greater than 10 to the 2nd power of a single uropathogen may be an appropriate cutoff to diagnose and treat someone with a urinary tract infection. Now, continued intermittent course of antibiotics can pose several problems, including allergic reactions, organ toxicities, C. diff infections, which I'll discuss in a future slide. This was an important article from Nature that discussed the epidemiology of urinary tract infections. I mentioned earlier that uncomplicated infections affect those who are otherwise healthy and have no known structural or neurological urinary tract abnormalities. Now, these infections we differentiate into lower urinary tract infections, cystitis, or upper UTIs, pyelonephritis. And there are a lot of risk factors associated with this, which you see some listed on the bottom left, including female gender, older and younger age, but also include a prior UTI, sexual activity, obesity, and diabetes. Complicated UTIs, they're defined as patients who develop UTIs that include factors that pose a higher risk for infections. And that includes urinary obstruction, urinary retention, which may be due to neurological disease, immunosuppression, renal failure. The primary pathogen here is UPEC, which is uropathogenic E. coli. We know in hospitals, in clinics, we often see patients who have indwelling Foley catheters. And in the United States, 70 to 80% of these complicated UTIs are attributable to indwelling catheters, and they account for over 1 million cases a year. Regarding the AUA guidelines, when we see patients, it's important that we obtain a urinalysis and a urine culture with sensitivity prior to treating patients for recurrent urinary tract infections. And we as clinicians can also offer patients self-start therapy, essentially to select recurrent UTI patients who are awaiting cultures during acute episodes. Now, for patients who are truly recurrent UTI patients, there are possible antibiotics that you can use after appropriate discussion of risks, benefits, and alternatives as prophylaxis to prevent the risk of these future UTIs. For women who have infections due to sexual intercourse, recommendations include Bactrim, Macrobid, and Keflex. And as you can see on the left, there are also women who have recurrent UTIs that can use continuous prophylaxis low dose. And so we typically use Macrobid in the clinic, but you also have the option of using Bactrim, Keflex, or fosfomycin. Keep in mind that the AUA guidelines also discuss that in a uncomplicated urinary tract infection in a patient, a course of Bactrim for 5 days, 1 tablet twice a day, or Macrobid for 3 days rather, and Macrobid for 5 days is also an option, or 3 grams of fosfomycin 1 time. We also, however, unfortunately, are susceptible to antibiotic misuse and overuse. There's increased resistance, adverse effects, and societal costs. And antibiotic resistance is one of our biggest threats to global health, food security, and development today. So it's important at times to use our local antibiogram. And it's not just urinary tract infections, it's a growing number of infections: pneumonia, tuberculosis, salmonellosis. These infections are becoming harder to treat due to our misuse. This resistance can lead to longer hospital stays, higher medical costs, and increased mortality. We also know some of the black box warnings we see from using medications such as ciprofloxacin, which in patients who have cardiac disease can cause QT prolongation, tendon rupture, of course, to name a few. I think Ben Franklin said it best, where an ounce of prevention is truly worth a pound in cure. In terms of what we can do to prevent these infections, aside from antibiotic use, we also have to consider non-antibiotic prophylaxis. In peri and postmenopausal women, clinicians can recommend or should recommend vaginal estrogen therapy to reduce the risk of future UTIs, assuming there's no contraindication. And of course, clinicians can also use cranberry prophylaxis for women with recurrent urinary tract infections. It's important to keep in mind these contraindications when discussing vaginal estrogen therapy. This is one common cream that's used, and we have to account for undiagnosed genital bleeding, any known or suspected history of breast cancer, or any estrogen-dependent neoplasia, keeping in mind deep vein thromboses and pulmonary emboli, histories of stroke, myocardial infarctions, any liver dysfunction, or known or suspected pregnancy. This can definitely be efficacious in patients where it's applicable, but keep in mind these side effects and make sure you rule this out prior to prescribing. In terms of how do these cranberry tablets work, there's an active component called PACs, or proanthocyanidins. Now, specifically, A-type PACs, which are found in cranberries, have an anti-adhesion effect on E. coli, and these prevent the sticking of the urinary tract cells to the uroepithelium. In addition, these studies have shown that bacterial adhesions are reduced with PACs, and also there's reduced E. coli-induced inflammation of blood, mononuclear cells, and macrophages. Now, not all cranberry tablets are the same. Some cranberry tablets have more efficacy than others. And it's important to know that the concentration of the PAC is important. Particularly, we recommend about 36 milligrams. Several supplements do carry those 36 milligrams and some do not. In my research, some of the tablets that I've noted do not mention PAC content at all, so do keep that in mind when prescribing. I mentioned A-type PACs. They also have B-type PACs, but their studies have shown that A-type proanthocyanidins have greater bioactivity than B-type PACs in terms of increasing that extraintestinal pathogenic E. coli from agglutinating and decreasing that extraintestinal E. coli invading epithelial cells. Utiva is one example of a supplement that has 36 milligrams of soluble PACs. The recommended dosage is 1 capsule daily at the same time, and the recommended dosage for sex-associated UTIs is 2 capsules, both before and after intercourse. It's also important to mention here that all vitamin K has been removed to minimize the interaction with blood thinners, and there are only trace amounts of oxalates, and that exists to minimize its impact on kidney stones. Capsule size matters. There are patients who have dysphagia, which may affect their ability to swallow tablets, and that may affect compliance. We see several patients in the office with lower urinary tract infections. One of the common medications we prescribe for that is tamsulosin or Flomax, but that capsule size has prevented patients from being compliant with the medication. So Utiva does have the smallest capsule size, and there are less fillers than some of its competitors. A quick Google search or Amazon search will show you several brands, companies, and varieties of cranberry tablets. Again, be sure to find companies that do mention their study methods, its efficacy, and the associated PAC content prior to prescribing. A common question or comment I get in the clinic is, why not cranberry juice? It tastes good, and they've heard that it prevents infections. Well, the sugar content is quite of concern. This is a screenshot from Foodjucate, which is a website that shows the nutritional content of some of the foods that we consume. And you can see from here that the sugar content is quite high. So that high sugar content should be kept in mind in patients that are diabetics. And in addition, the most common stones we see in America, in the US, is calcium stones. And calcium oxalate is one particular stone that's commonly represented. So high oxalate content in juice would worsen the situation for stone formers. As I was discussing things that can help prevent infection that are not related to antibiotics, I cannot stress the importance of oral hydration enough. And this was a particular study done by IROS that talked about the trial of women with recurrent urinary tract infections who reported less than 1.5 liters of fluids per day at baseline. In the study, the daily fluid intake increased from less than 1 liter a day to 2.2 liters per day in the increased water intake group. This increased water intake was associated with fewer UTI recurrences, a mean of 1.7 versus 3.2 UTI episodes over the course of a year, which led to a lower likelihood of having at least 3 UTI episodes over the course of a year, and a greater interval between these UTI episodes, 143 versus 84 days. A quick sidebar on stones and urolithiasis. I mentioned in the last slide and how the participants increased their water intake from 0.9 to 2.2 liters per day. For stone prevention, clinicians should recommend a fluid intake that will achieve a urine volume of at least 2.5 liters per day. And it shows the high importance of hydration. Clinicians, we should also counsel patients with calcium oxalate stones and relatively high urinary oxalate to limit the intake of oxalate-rich foods and maintain a normal calcium consumption. And this highlights the importance of these fillers that are placed in these supplements. Minimizing oxalate is extremely important. We also hear in the clinic and office, and just from conversations with colleagues, about other things that may play a role in the prevention of recurrent urinary tract infections. Horseradish has been suggested, as has lactobacillus, methenamine, herbal therapy, intravesical hyaluronic acid, chondroitin, biofeedback, and immunoactive therapy. However, none of these have demonstrated conclusive evidence. The studies shown on the AUA guidelines on their deep dive showed promising data for intravesical hyaluronic acid, but nothing has been proven clinically, and additional research is needed prior to providing a recommendation. Regarding D-mannose, there has been conflicting information. The AUA guidelines have suggested that there's inconclusive evidence. However, an article from Nature by Zachary has suggested that D-mannose can cause saturation of these FIMH receptors, as you can see on the associated diagram. It can cause saturation of these adhesions and prevent bacteria from binding to urothelial glycoprotein receptors. Now, D-mannose in the future could be considered as an alternative to antibiotics in treating uncomplicated UTI in women and reduces the risk of recurrence. And again, larger randomized trials are required. It's also important to keep in mind that if you do recommend D-mannose in conjunction with cranberry prophylaxis, it's important to space that out, as D-mannose can have a negative impact on the role of proanthocyanidins. There are some other myths that we see, which include front to back wiping, precoital and postcoital voiding, the avoidance of hot tubs, and tampon use, to name a few. Unfortunately, these case control studies, they demonstrate that changes in these hygiene practices do not play a role in recurrent UTI prevention. There's an app developed by a urologist, Dr. Dana Rice, that helps patients track their UTI recurrences, medications, provide reminders, and it provides a voiding diary and allows for the export of data. Oftentimes, we see patients that have mentioned that they have had infections for several years, but we're not aware of what pathogens have afflicted them, what duration, and what is a true symptomatic effect on them. They mention, I've had several infections, but it's difficult to quantify. So oftentimes we're not aware of which medications have they tried, have they been efficacious, or have there been any negative side effects from that? How many exact years of infections have they had? Is it a worsening trend or is it improving? There's no voiding diary to get a sense of any caffeine intake or the amount of hydration they have or lack of hydration. And then more importantly, any change in resistance patterns. Have they been given the same antibiotic over the last several 4, 5, 10 years that is no longer effective, but they keep being prescribed that. Some final thoughts I wanted to prescribe. Just practicing evidence-based medicine. There are the American Urological Association guidelines and also the excellent Canadian Urological Association guidelines that we can use to further direct evaluation, management, and treatment. When we see patients who may have symptoms of dysuria or urgency, frequency, suprapubic pain, or the like, we must consider other diagnoses that are not necessarily UTIs, which may include but are not limited to dehydration, urolithiasis, interstitial cystitis, or malignancy. In addition, do not treat ASB in patients. ASB, again, being asymptomatic bacteriuria, and exceptions include pregnancy and a planned endoscopic urologic procedure. Work with your local physicians and healthcare providers to come up with a treatment plan that is best for the patient to maximize compliance and minimize side effects. And of course, reach out to companies for free patient education. Use your own discretion and trust but verify. There are studies that have been conducted. They're more than happy to provide these studies to show where the work has come from. And let's work together to help prevent infections. Thank you guys for coming.
Great. Thank you so much, Dr. Shah, for your presentation. I'm sure I'm not the only one who found it to be very informative. We have quite a few questions waiting to be answered, so let's jump into the Q&A.
Excellent.
Okay. So first question here is, do you treat yeast in the urine, especially if the patient has an indwelling Foley catheter?
Yeast in the urine can be treated. The issue oftentimes is we would see in residency, particularly with patients with indwelling catheters, indwelling stents for an extended period of time, with multi-drug resistant yeast. So unless they're particularly symptomatic, I would not treat it. If they are symptomatic, then I would. Oftentimes, this is due to foreign bodies. Okay. And the first thing would be to exchange that foreign body or remove the foreign body if appropriate. If it's an untreated stone, treat the stone. If it's an indwelling catheter, assess why they have that indwelling catheter and change it as needed.
Okay, thank you. Second question, what would you recommend for a patient with breast cancer who is estrogen positive?
A lot of this is evolving with your local gynecologist or OBGYN physician. With cranberry prophylaxis, it's not a problem. With the estrogen therapy, I would be very careful. As I mentioned on the contraindications, in women who have any estrogen-dependent neoplasia, estrogen therapy is contraindicated.
Okay, thank you. So especially for inpatients, how do you teach not to send the urine for urinalysis and culture for complaints of smell and or cloudiness? Is that clear?
Yes, that's a great question. And that's something that we see all the time. And I think this really comes down to education as the most important thing. I think by nature, when patients present to the office of a healthcare provider, whether it's an annual visit or if they're actually acutely symptomatic, it becomes a reflex to want to send a urine. We have patients that will have a ureteral stent placed or a foreign or a Foley catheter placed for urinary retention. As we all know, across the world, there's a shortage of healthcare providers. So sometimes these indwelling catheters remain in place for longer than we'd like. And when they come into clinic, a lot of healthcare providers do check a urine. I would advise against that because each day a foreign body is present, there's a 5% chance of colonization. So theoretically, after 20 days, there would be a 100% chance of urinary colonization, but it doesn't necessarily mean that the patient is symptomatic. So the question referenced about people who may have malodorous urine and how we can prevent that. And I think a lot of that just comes down to education. It's just working with our nurses, our staff, and our patients as well who demand it. If they're truly symptomatic, and that's a different story, and that should be assessed for and treated. And it really is shared decision making at that point. But it's important to assess that if we're going to check a urine, it's for the intent of treating it. There's no point in getting a urine, seeing a pathogen grow on it, and then not treat it.
Okay, thank you. Great answer. Okay, so hold on, let me read this one properly. So for local estrogen that's not topical, oh wait, no, okay, so I'm just trying to read this correctly. Local estrogen, not topical, is used in urogenital conditions, including cystitis for peri and postmenopausal women, including women with breast cancer without the increased risk due to low risk of systemic absorption. Can you comment further on this?
Yeah, there's a low risk of systemic absorption. That's something to consider, and it can be used. The main thing is just working closely with our oncologists and our GYNs to make sure that with the minimal systematic absorption, that this doesn't cause any other long-term negative outcomes.
Okay, thank you. So do PACs proanthocyanidins work on non-E. coli pathogens?
That's a good question. The primary studies, this was done by Amy Powell at Rutgers University in New Jersey. And her primary worked on PACs on E. coli, the primary studies. I don't have any current data on other pathogens as well, and I think for additional research is needed on that. But the primary studies have been in E. coli.
Are men still considered complicated and need longer antibiotic treatment, especially older males with or without a Foley?
Okay. So these guidelines were based on a recurrent uncomplicated UTI in women. And so there are no full concrete guidelines established on men. In men who have a Foley catheter, the question is assessing why they have the Foley catheter. Is it a temporary reason, for example, post-operative surgery, or is it due to something more long-standing, such as neurogenic bladder or full-blown acute retention? I have prescribed cranberry prophylaxis for men who have indwelling catheters, and they have noted significant benefit from them. I would consider males complicated in that sense, and I would recommend a longer course of antibiotic therapy in symptomatic men. It's also important to check a repeat urinalysis and culture after treatment to make sure that they have cleared that infection. And this is particularly important in men as they get older, as we often, as urologists, screen for prostate cancer, and a urinary tract infection can cause a spurious or a false elevation in PSA. So a longer course is recommended, obviously tailored to the sensitivity of that urine culture, rechecking it, and then making clinical decisions based on the new results.
What is your opinion on the use of urine PCR tests?
I think urine PCR tests are very effective. Oftentimes, we get results back from urine cultures that are completely negative. Patients are still symptomatic. So in patients who have very multi-drug resistant urine cultures, or they're not responding to prior therapy, or they're still symptomatic and have several negative tests, PCR testing would be the next step in clinical testing and diagnosis.
Okay. So this is about a patient on intermittent catheterization due to atonic bladder. They get frequent UTIs. I alter prophylactic antibiotics. What else can I do? That's
a great question. First of all, I commend this individual asking the question on CIC. Clean intermittent catheterization is definitely better than an indwelling catheter. In terms of what else can be done, it's an atonic bladder, but increasing hydration, assuming there's no renal failure, is something to keep in mind. Cranberry prophylaxis is also great as well, but it's also keeping in mind what I mentioned earlier about each day indwelling a foreign body is in place. That's a 5% chance of colonization. So really assessing if they're symptomatic. And if they are, then absolutely treat that infection and assess that their symptoms have resolved. But their urine cultures will still be positive if they've been on long-standing clean intermittent catheterization.
Thank you. Next question, are there conflicting opinions regarding asymptomatic bacteriuria in pregnancy?
Yeah, I mean, I think there's going to be conflicting, opinions on everything. In pregnancy, it is something that is quite important, and that's the reason that it's checked much more frequently in pregnant women, and that it's treated in pregnant women as well. The same goes for what I mentioned earlier in that slide of patients with planned endoscopic urologic intervention. You want to make sure that you clear that infection to the best of your ability prior to going forward.
Thank you. Okay, next question. Can you explain no significant growth and mixed growth? Is this a UTI?
We see this all the time. So the main thing is a lot of times when a result comes back from a laboratory, it'll say growth of mixed flora was suggesting possible contamination. This could represent external colonizers. No further susceptibility will be performed. I see this 50 times a day, which is why I've memorized it. When we often ask patients to provide urine samples, we oftentimes forget or don't have the time because we're extremely busy. But that proper collection of that sample is really, really important. And so we call it a clean midstream catch sample, of course. And we want to clean first. Those initial 10 mLs, or I tell patients 3 to 4 seconds, should be voided with the remainder collected in a specimen cup. In patients that continue to have contaminated urine, despite best hygiene practices, we can consider obtaining a catheterized specimen if needed.
Okay, thank you. All right, so next question. Utiva has a probiotic, but as noted earlier, lactobacillus has no conclusive evidence. Would you recommend the Utiva probiotic use?
Yeah, again, it's using your own indiscretion. There is no clinical evidence on lactobacillus. Some clinical trials have shown efficacy with it. Some trials have not shown efficacy with it. The main thing is doing your own research and seeing if it's efficacious. Some patients also have GI or gastrointestinal disorders, and they're taking a probiotic for that reason. So a lot of it's doing your own discretion and seeing if it's indicated.
Okay, great. What do you recommend for recurrent uroplasma UTI?
Current uroplasma UTIs, I think PCR testing is something that would be beneficial here. Oftentimes, a lot of urine cultures do not pick this up. If they continue to be resistant or difficult to treat it, then I would consider consultation with an infectious disease specialist.
Okay. I've seen many gynecologists treat greater than 28-week gestation women with macrobid. However, I thought it was contraindicated after 28 weeks. Is this true? I use Keflex instead. Any reason to use macrobid instead after 28 weeks?
There could be fetal abnormalities with use of macrobid. Keflex is completely fine as an option, being a cephalosporin. The main thing is minimizing any chance of any issues. And so at a certain point, I would contraindicate using macrobid.
Okay, great. What is your choice, dosage and duration, for outpatient pyelonephritis? Cipro has warnings. Do you worry about Septra and risk of Stephen-Johnson syndrome?
Yeah, so Cipro used to be a common antibiotic that we used to use, and obviously with all the black box warnings, regarding Septra, Stephen-Johnson syndrome, there's also T10, which is toxic epidermal necrolysis. The risks of these are quite minimal from happening. We use Bactrim commonly for that. If they're in an inpatient setting, a gram of Rocephin, which is ceftriaxone, is also commonly used. In patients, it's important. Follow-up is extremely important. If patients do exhibit any symptoms, including a rash or anything like that, first step is to remove the offending agent and get in touch with your healthcare provider. So I think discretion is obviously extremely important, but I've yet to see a case, and I hope to never see a case of any patient with Stephen-Johnson's or 10.
Thank you. Next question. We have a lot of questions. Is risk of pulmonary fibrosis a concern with macrobid if taken often post-coitally for recurrent UTI?
So some of the evidence has shown that it can increase that risk in the long run. But one thing to mention that when people do use continuous antibiotic prophylaxis, the duration is really, really important. So we do have patients on Bactrim and macrobid pre or post-coitally, and they've had great results from that. It's also worth considering ramping up non-antibiotic measures during that time period, which again I mentioned earlier, including that hydration and the cranberry prophylaxis, and then having a prophylaxis break, essentially. The AUA has suggested, but don't conclusively recommend, that these durations of antibiotics be 6 to 12 months. Obviously, everything has exceptions, and some things are on a case-by-case basis. But the duration of therapy is really important when considering continuous prophylaxis.
Thank you. Okay, this is an interesting question. Does circumcision reduce the risk of penile and urinary infections?
It can, yes. There are patients who do get recurrent infections. There can be ballooning at the distal aspect that can predispose to infections. One of the main indications that we urologists circumcise is regards to penile cancer. If it's essentially done near birth, it can eliminate that risk. After puberty, the risk is the same as someone who was never circumcised for penile cancer. But yes, it can help decrease that. In younger pediatric patients, they can be susceptible to vesico-ureteral reflux, which can contribute to infections, and they may be associated with bowel bladder dysfunction, things of that nature, but circumcision is an option.
Okay. If a man has systemic symptoms such as fever, malaise, chills, with typical UTI irritative symptoms, do we always empirically treat for prostatitis and treat with a 2 to 4 week of antibiotics after culture?
Not necessarily. First thing would be, if you're febrile rather, the first thing would be to seek evaluation in an acute center or an emergency department. At that point, you're worried about fevers. You want to assess for not just urinary tract infections, but is there any systemic infections going on? So I would treat that in the acute setting in terms of getting urine cultures, blood cultures, and you can start empiric antibiotics, empiric broad spectrum antibiotics after obtaining those initial urine and blood cultures with hydration. We'd always check a post-void residual to make sure these patients are not in retention. And after their system is cooled down, and if they're having different types of, if you're concerned about prostatitis, then you can follow that pathway.
Thanks, Dr. Shah. Jyoti has a bit of noise in the background, so I'm going to help continue to ask. We have about 5 more questions here for you, okay?
You got it.
All right, so next question. What is your opinion on gentamicin bladder installation for chronic SPT or indwelling catheter use?
So there is no conclusive evidence on using intravesical gentamicin. I do know clinicians from residency that did use an irrigation method of gentamicin. It goes back to what I was saying before, again, that we just have to keep in mind a colonization, right? Any indwelling catheter it becomes an issue with colonization, and patients absolutely can become symptomatic from that. And that is when a urinalysis and culture with sensitivity is recommended. Switching to clean intermittent catheterization is likely one of the best moves. Of course, if patients have the inability to self-cath due to different deficiencies, then that would preclude that from being the case. But I don't think it is recommended for every patient to use that.
Okay, thank you. We have a bunch of questions still. There's one interesting one that just came in that I've never seen asked in all the talks that we do. So I'm going to ask you this one here. Does anal sex increase risk of enterococcus positive UTI?
I'm not aware of any evidence on that, but I would have to do more research on that.
Okay, thanks. First time that question has come up talking about UTI, so I figured make sure we get that one out. When do you test for urea plasma?
Test for urea plasma. So there are a lot of patients that have recurrent symptoms, and usually including dysuria, and we've upped the water intake, but they're still symptomatic with associated degrees of urgency and frequency. And if the results continue to be negative despite a long-standing history of these symptoms, then I would recommend proceeding with other methods, including PCR, testing for uroplasma, mycoplasma, to see what the true etiology could be and rule that out.
Okay. Next question here. Would you say that E. coli in the urine could be due to an increase in antibiotic usage?
One more time.
Would you say that E. coli in the urine is due to an increase in antibiotic usage?
So, E. coli, as you saw in one of the earlier studies by Nature, in both an uncomplicated and a complicated infection, it's the primary uropathogenic pathogen. But one of the main things is, regarding antibiotic misuse and overuse, what ends up happening is when we misuse and overuse, we end up just creating greater resistance profiles. And patients also have not just recurrent infections, but persistent infections, where we will treat a patient for an infection. They may or may not complete that course of antibiotic therapy, and a repeat culture demonstrates the same pathogen, except more virulent, in the sense that there are less antibiotics that they're susceptible to. So I think it's just being mindful of what we're doing and making sure that we truly do clear infections, and using all the non-antibiotic prophylaxis to minimize the chance of these from recurring.
Okay, thanks. For a patient with a history of recurrent UTIs having urodynamics, do you ever give a dose of fosfomycin?
So we don't give fosfomycin. We do give a dose of gentamicin in the office to help prevent infections. This definition by the AUA is loose in that sense of what they consider complicated and what may or may not warrant a prophylactic dose of an antibiotic before an office procedure. And I think a lot of this comes down to using your best judgment. If you have a pre-procedure urinalysis and culture within a time frame of 14 to 30 days, it may not be indicated. But in a patient who may be at higher risk, that is something certainly to consider.
Okay. Okay, I have this question here. I'm hoping I can say everything properly here, but what do you use for epididymitis, non-gonorrhea, non-chlamydia, IC only fluoroquinolones? What about chronic prostatitis? Does that make sense?
No, one more time.
What do you use for epididymitis, non-gonorrhea, non-chlamydia?
Okay. So these are obviously very common sexually transmitted infections. And so in younger patients, usually we try to risk stratify below the age of 35 versus the age of above 35. The pathogen tends to vary. In patients who tend to be symptomatic, the old thinking was more based on ciprofloxacin, and we've talked extensively about some of the side effects from ciprofloxacin and how it has a black box warning, tendon rupture, QT warning, QT elongation. Considering a course of Bactrim or doxycycline is warranted. The typical studies in the past have demonstrated the usage of these medications for a period of 4 to 6 weeks. But what I tend to do is use a 2-week course, see if it's effective prior to continuing on with therapy. And this is in combination with not only antibiotics, but considering non-steroidal anti-inflammatory drugs such as meloxicam, plus or minus alpha blockers.
Okay, thank you. You know what? So we have 3 more questions, and we're gonna have to cut it off at that point. So the third last question here: what is the mechanism for UTIs in women who hold their urine?
With urinary stasis, it's going to predispose patients to all sorts of complications. Obviously, urine being a waste product, our goal is to expel it. So the first thing I'd recommend is not to hold on to their urine to basically, essentially get rid of it. But you allow any current bacteria in the urine a longer chance to stick to the uroepithelium, which may predispose someone to developing an infection. You can use measures to help prevent that from happening, such as PACs, to prevent that sticking, essentially. The reality is the best way to prevent this is to just to urinate at timed intervals and not hold urine.
Thank you. All right, second last question here. With microbiomes of different organs talking to each other, does going on a healthier anti-inflammatory help UTIs?
I can't stress the importance of diet in what we do. We'll have patients that we diagnose with prostate cancer, and they'll ask what diet can they take. There's no particular diet for any of these things, but the reality is I think diet is just as important as anything else that we do. So a high intake of fruits, vegetables, water, as I mentioned earlier, all of these things I believe do play a role. I don't have any clinical papers written showing that eating a certain amount of this proportion is going to help prevent infection, but an overall healthier diet has long-term advantages.
Okay. And for our last question, you talked about CIC earlier, but we're going to ask this question anyways here. When you first teach CIC in a patient for neurogenic bladder, do you start them on a course of prophylactic antibiotics for the first 21 days?
No, I do not. I would always have a urine checked beforehand to see if there is any pathogens I need to worry about prior to initiating CIC. If it comes back positive, that's something we can discuss and talk about. Starting a course, it's not the standard of care by any means. The frequency of CIC also really matters. There are patients that I will see that will CIC only twice a day, and they may retrieve over 1 liter of urine a day. That's not healthy for overall bladder health. Understanding they already have a neurogenic bladder, but you're also more worried about their upper tracts, particularly the kidneys. And you ideally want to achieve volumes between 250 and 400 milliliters. So if it means increasing the interval at which they CIC, that's what I would recommend. Obviously, don't reuse catheters, and also consider prophylaxis. I mentioned earlier that in our country, 80% of these infections are due to complicated UTIs, due to indwelling catheters, and indwelling is not the way to go.
Okay, well, hey, that was outstanding 27 questions that we got through there. So we appreciate your time, and Dr. Shah, thanks so much for taking the time to speak with us and to do your talk and to provide your knowledge and share that with everyone. There's such a variety of attendees here that I'm sure everyone definitely learned a few things that are new. And if you have any last words you want to share, other than that, you're welcome to drop out when you're ready. And we will, if anyone wants to hang on, we are going to do the iPad raffle. So just hang on just for a minute while we get that set up.
Awesome. I just want to thank all you guys for taking time out of your busy schedules to listen to this talk. And I appreciate all the great questions. And if you have any other questions, please feel free to get in touch with me, and I wish you all the best. Take care.
Thanks, Dr. Shah.
Bye-bye.